Drew, do you hear everything well?
Yeah, Len, I can hear it.
Okay. All right, Mike, you ready to get started?
Sure.
All right.
Morning,
So,
my name is- oh, go ahead.
Speaker, I'll just give you a minute introduction. Dr. Michael Mallahan, the best audiologist that I know I wouldn't hear this presentation if he hadn't straightened out my ears. But every year, every other year, he kindly gives us a presentation, since I think functions of the ear and diseases of the ear are something that physicians, in my experience, are not taught very well, and yet something really very important, especially for allergists and pediatric allergists. So I met him when he worked at Hearing and Balance Lab up in Mill Creek. Now he's doing many other things, including very essential volunteer work down in Central America. Anyway, he's going to go ahead and do audiology for allergists.
Morning. My name is Mike Mallahan, audiologist. I have no disclosures. Be sure to mute your microphone if you come on. My background is I got a doctorate in audiology from the Arizona School of Health Sciences at Still University, Mesa, Arizona. I joined an otolaryngology practice in 1982, and in 1994 opened a new practice, Hearing and Balance Lab, which I just left last year, seeing newborn infants to adults for hearing and balance related problems. My specialization is in balance disorders and pediatric assessments. I opened a new practice. This past year, doing medical legal work and consulting for the Veterans Administration. I lead medical teams to Guatemala. Used to be twice a year, but COVID slowed things down. But our next surgical otolaryngology team will be in May of this year. And I just returned from a couple of weeks in Guatemala in preparation for that event. An audiologist is a specialist involved in the assessment of hearing and balance issues, and then recommendation for treatment. From the day of birth, we provide newborn hearing assessments within 12 hours of a child's birth to determine if they have normal hearing or not, because hearing loss is the #1 birth defect. It affects clear deafness in 1 per 1,000 infants, and 6 per 1,000 infants have a educationally significant hearing loss, more commonly permanent or temporary. An audiologist is required to obtain a doctorate in the field of audiology. There are about 12,000 of us throughout the United States, some at the university, some in research. Majority of us are in clinical work, either in private practice or medical centers. Some work with industry, such as the Boeing company, and a number provide help in local schools. As I said, hearing loss, #1 birth defect. If it's not identified early, it has lifelong consequences. A child that is not identified with hearing loss has significant delays in speech and language acquisition, and then goes forward in producing issues, obviously, for academic achievement. In the United States, there's a lot of folks that have hearing loss, either that is early onset or acquired during their lifetime, and has dramatic consequences to achieving economic opportunities and significant impact on their social interaction with family, friends, and colleagues. Balance disorders and dizziness is the #1 reason to go to the ER. So let's talk about how the ear works. There's commonly three sections, the outer, middle, and inner ear. The outer ear is comprised of the auricle, the external auditory meatus, going up to the tympanic membrane. The middle ear is comprised of the tympanic membrane and the ossicular chain, the malleus, incus, and stapes. The middle ear space is comprised of a mucosal lining that then goes down to the eustachian tube, which goes to the back of the nasopharynx. The middle ear space is the thickness of a dime and a nickel together, so it's not very large. Inner ear is comprised of the cochlea, which deals with hearing, and the vestibular system, which deals with balance. I'll describe those a bit more. So as I said, the middle ear space is a mucosal lining, and that is something of interest to allergists because of the inflammation of that causes middle ear problems, which causes hearing loss, either temporary or chronic, and can be influenced by allergies. We look at the cochlea. Lining the wall of the cochlea is a membrane, and sitting on top of that membrane are hair cells. Underneath of those hair cells are supporting structures that then tie into nerves that then translate to the brain through the internal auditory canal. Going back a bit, sound is generated and enters the outer ear canal, hits the tympanic membrane, causes it to vibrate, which then transfers to mechanical action to set the stapes into a plunging action, which then sets up a fluid wave that travels to the cochlea, causing the hair cells to bend over, triggering electrical stimulus to send a signal to the brain. Interestingly enough, when that signal fires to the brain, it actually fires back out of your ear. So whatever goes in your ear comes back out as a generated signal. And luckily, we have the ability to measure that signal and determine if the system is in fact working. It doesn't tell us what the brain does with that data, but it does tell us about the function of the cochlea and the most common issues for hearing problems. If there's fluid within the middle ear space, that cannot be measured. If there's deafness, that can be measured, and we can quickly identify. It takes about 30 seconds per ear to tell us if the hearing is normal or not normal, and then we can deal with the consequences of that. So testing that we do, one of the things is called tympanometry. It's a measurement of middle ear compliance. We put a low frequency sound into the external auditory canal. It then generates a pressure change from positive to negative pressure. And we take a look at how well the sound travels through the middle ear space and how well the eardrum moves. It tells us if there's a presence of fluid, if there's a thickness of the tympanic membrane, or if there is a restriction in the ossicular chain movement, which can be caused by a phenomenon called otosclerosis, or a hardening around the stapes foot plate. Otoacoustic emissions is the test that we do to measure the response of the cochlea generating a sound back out. Middle ear muscle reflex is a reflex that occurs along with tympanometry that tells us a loud sound goes into the inner ear. It's sent out to the brain at a certain loudness level. At the brainstem level, it sends a signal back to make a muscle contraction that then stiffens the middle ear system and dampens down the sound coming from outside to inside. It also tells us about the functional performance of not only the cochlea, but sending the data on up to the brain. It's a crossed reflex. So if there's a mass that is affecting the transmission of sound, this middle ear muscle reflex will be absent. It's not measurable when there's middle ear fluid present, but it tells us a lot of things. And it's the one reflex that occurs just before we start talking that dampens down the loudness of our voice when we talk to others. It can go into spasm. The superiomyoclonus can come into place, and it makes it sound like there's a butterfly flapping their wings, and in the outer ear canal is quite disturbing. Audiometry is a simple measure of hearing acuity by pure tones of different frequencies. Gives us a plot of hearing sensitivity. Speech and noise test is a test where we take a look at people's understanding in a complex environment. Brainstem auditory evoked responses, or BARE, is the measurement of the signal going from the cochlea on up through the brainstem on up to the cortex, and we can measure the function and transmission of signal. Common causes of hearing loss are noise exposure, particularly nowadays. Very many students are walking into high school with a noise-induced hearing loss due to their musical interest or other activities. Noise exposure obviously causes damage to the ear from those that work in industrial settings. There's more and more that is occurring less and less because people are wearing hearing protection in the workplace. Certain medications can cause hearing loss. Aminoglycosides used to treat infections and other issues. Chemotherapy medications also affect hearing, so we monitor hearing acuity while receiving certain medications to try and manage the change. As I'm well aware, the aging process also produces impact on the supply of blood flow, nutritional support to the stria vascularis within the cochlea. And so as things change and the blood supply changes, primarily the upper frequencies are affected, causing difficulty understanding speech and noise or understanding your spouse from the other room. A number of different diseases impact hearing ability, and head trauma can create problems. So, what are the effects of hearing loss? Obviously, communication is an issue with family and friends and colleagues. If you don't hear well, it creates a barrier to clear communication, and that creates social emotional issues. We become crankier, we become fatigued after working hard to follow conversations in a complex signal with background noise. A lot of cognitive load is placed on hearing, which then creates other stressors. Economic consequences is an example of a hearing loss and its effect on household income. The greater the hearing loss, the greater impact on the ability to gain economic advancement. So the other thing is, if you lose the information through aging or other issues, it changes the response within the cortex. When you don't get the data supplied from downstairs to upstairs, the brain goes on to other things, and you have significant issues with cognitive decline, significant evidence of higher onset of dementia with untreated hearing loss. So if you don't get amplification, if you don't get treated for the hearing loss, you have significant changes to your processing capability. And if you get hearing aids late in life, your ability to gain benefit is significantly less than if you would have gotten on the bus earlier in life. No matter how many times spouses suggest that their loved ones get help with hearing, the common thing is 7 years before a guy will go and get help. And there's only about 2 years for women, because they're smarter than men. Tinnitus is another side effect of a number of things. It's noise in your ears. It's either a roaring, a buzzing, a humming, a whistle, a whine. It's something that is there and present all the time. You can't get away from it. It can affect your sleep. It can affect your concentration. And we see a significant number of folks coming in complaining about tinnitus. Hearing aids help suppress some of that, some of the tinnitus. And in fact, for 60% of folks, getting hearing aids, they won't hear their tinnitus at all until they take the hearing aids off. So it's a significant issue. Next, talk about dizziness and balance. That's one area of my interest, and I've spent going on 40 years now of evaluating people for balance disorders. It's a very common thing. There are a large number of folks that go to their physician for problems with balance. Most commonly, it's an acute episode where they get a spinning sensation, either with movement of their head or they get a sudden onset of vertigo, which persists from days to weeks and is quite dramatically impacts people's lives. So how does the system work? We use 3 different systems for input to maintain our equilibrium. Our eyes tell our brain where our body is in space. It tells our brain where we are in reference to other objects, so depth of field. Proprioception is a musculoskeletal system telling the brain about where our feet are, where our rear is when we're sitting in the chair, and where as we're moving about in space. So that feeds information to our brain about our position and help with our equilibrium. The vestibular system is those 3 semicircular canals within the inner ear that provide orientation to direction of head movement and the plane that the head is moving in. And that makes adjustments to where our eyes move and also to where our body moves. So it controls the other 2 sensors. And if one of the sensors gives bad information, it's going to cause disequilibrium. If the vestibular system is out of whack, it's going to cause all kinds of problems. And the brain depends on the vestibular system over anything else. No matter what the eyes tell the brain, no matter what the body tells the brain, if the vestibular system says you're going in a different direction, you're going to be turned in that direction. And the eyes lie. Here's an example of what we perceive in our environment. And I'll ask you to take a look and maybe move your head or blink your eyes and tell me how many black dots there are on that screen. There are in fact no black dots on that screen, but our eyes fill in what's not there and gives a reference that is in fact not true. And that can give us bad information. Vestibular system, like I said, is comprised of these 3 semicircular canals full of fluid. And at the end of each canal is a cupula that, as we move our head from side to side, it distends the cupula, causing it to fire a signal to tell the brain the direction that our head is moving. 3 planes of movement are represented in the 3 canals. And that then sends a signal to our eyes to adjust our eye position. It also sends a signal to our sternocleidomastoid muscle that adjusts our neck position and our head over our body. Within another area called the otolith, which is in the middle of the system, is a system where there are a pile of rocks called otolith crystals that are calcium carbonate in nature. They sit on a bed of jello, and as you move the body, the jello moves, and it stimulates the crystals to move, and that tells the brain the plane that your head is moving in and how fast you're moving in that plane. And that then sends a signal to the system also for managing your vestibular system. So what do we do to measure that function of those systems? One, we do dynamic tests, just to stand in one place with your eyes open, your eyes closed. May have you sit in a chair and then get up quickly and start moving and take a look at, it's called the Tonetti get up and go test. Just functional movements of balance to see what strategies a patient uses to maintain their balance when they're moving about in space. Another measure we perform, we use infrared video goggles we put on the patient. We have them do a number of positional tests with their head back, their head to the right, head to the left. Central vestibular tracking, we have them look at different eye movement tasks and take a look at what their eyes do in response to a stimulus. We also use a test called calorics, which produces warm and cool air into the inner ear and stimulates the horizontal canal, which causes it to fire, and we measure the response. and compare one side to the other and see if there's an asymmetry in the response to the system. The video head impulse test, where I jerk patients' heads back and forth and measure what their eyes do compared to what their heads do, and they should be exactly opposite and equal in response. And if there's an error in the system, I can measure that error. Posturography, you stand on a platform in a harness, we move the platform, we move the visuals around, and we take a look at how a person responds to the different stimuli. The floor will move quickly fore or aft. The patient does not know what direction the world is moving, and they make an adaptation to that system. Another test is vestibular myogenic potentials. We put electrodes around the eyes, we put electrodes on the neck, and then we stimulate the inner ear with a sound blast and measure a response to see if the eyes are doing what they should be doing when stimulating, and also what the sternocleidomastoid muscle does in response. So these are some of the equipment that we use for measuring balance function. Up at the top left is the video nystagmography goggles. The center is the head impulse test measurement. You can see there that I'm looking at the patient's eyes as we perform different functional measures. Bottom right is the posturography assessment, where the walls, the floor moves in response to the patient movement, and then the patient reactions. So it's a fun thing to do, to torture patients to identify their problems. And we put all this data together along the patient's history to determine what either medical or pharmacological or physical therapy treatments are necessary to restore their balance function. COVID impacts on hearing is more and more information is coming out. Early reports tell us that there's dramatic impacts on the vestibular system that is not fun. If there's an error in the system, you can't fix it, so you have to retrain the brain to compensate for that bad data. But when you're tired or fatigued, it raises its ugly head, and then you're now quite disturbed and have functional issues. Tinnitus and hearing loss are also another side effect that have been found to happen with COVID. And I'm sure that we will find more and more things as the world evolves. But that is my information, and I am I've run through the description quickly, but I would like to open up the meeting to questions.
Thanks very much, Mike. Do you have any questions out there? Got a fairly large audience. As I was listening to this and the complexity of this system, I'm just curious if you have any idea how this all evolved, at what point in development the complexity of our hearing and balance system developed?
The balance system, the vestibular system, actually is the very first thing that forms in utero. It forms before the heart because it forms before everything else starts, because the vestibular system tells our orientation in space. It tells the fetus what is up and what is down, and that has to function right away. So that is one of the first things to develop in utero. Hearing wise, we can hear for the last, after 6 months of gestation, we're hearing all the systems are intact and functioning well. So we hear for the last 3 months prior to birth. So providing good music to the baby in utero is good planning. By the way, the word of the day is Squid Games. It's not my choice, but it's somebody else's choice. You can see right there on my lifelong, well, since 1974 Sounders fan, and that is my interest. So one of the chat questions here, let me pull that up. So the questions that question came in, can you comment on unilateral pulsatile tinnitus causes and possible treatments? Unilateral pulsatile tinnitus can be caused by a number of things, and some of them are rather nasty. And so a neuro-otology assessment would be the first. Would be the first reference after doing some diagnostic assessment. Pulsatile tinnitus can be a new onset of tinnitus with stipiomyoclonus added on, so you get a pulsatile sensation because of the fluttering of the stapedius muscle. So it may in fact be a single frequency tinnitus sound that then is turned into a pulsatile signal with the muscle contracting. But pulsatile tinnitus can be also a cardiac issue. There are blood supply coursing through right in adjacent to the middle ear space. And so if you get tortuous changes to the carotid artery, you can actually hear changes in blood flow, and that's, you can hear that through your middle ear space. And so that's a cardiac issue, a blood flow issue. Those are the most common reasons for pulsatile tinnitus.
So pulsatile is sort of a specific variant of tinnitus?
Yeah, pulsatile is you can hear, and sometimes you can actually hear your pulse rate through your ear. And when you lay in bed, you hear the blood coursing through the system, and that gives you that pulsation sound. Pulsatile is just you hear a rhythm to the internal signal. Most tinnitus is steady state. It can vary in loudness and throughout the day. It's most commonly noticed early in the morning because you're laying in bed and it's perfectly quiet and it's loud and clear. Throughout the day, it can be masked by just the noises of life as you're moving about and doing different things. And then when you sit in a quiet room, you're trying to read a book, you're trying to relax, there it is waving the flag saying, pay attention to me. And it can be very disturbing, creating significant issues with mental health. And many folks have had such a bothersome tinnitus that they end up committing suicide. There's a recent William Shatner's famous for having tinnitus, said he contemplated suicide because of his tinnitus, but it's something that has to be it can be very well managed, but the first thing is we need to eliminate some of the medical issues that can be managed. High blood pressure is another thing that will cause earlier onset of tinnitus. If you take too much aspirin, your ears will start ringing, and that's the one medication that if you stop taking it, the tinnitus commonly goes away. Other medications will cause the tinnitus to come on and it doesn't go away. There's a huge number of folks that suffer from tinnitus, and I'm part of the club. I've achieved all the problems that I see patients for.
Well, I always found, at least in practice, the most common thing that patients thought was an allergic condition was when they had Menieres disease. And as I think people in our specialty don't believe there's any allergic component to Menieres disease. I think there's confusion in the field, though, confusion in the literature. You want to comment on that?
Yeah, a lot of the past belief that Meniere's is caused by an allergic reaction, but most commonly Meniere's is rears its ugly head when you have a high sodium intake. But it's now believed to be an autoimmune issue in some sections of our group. But Meniere's disease is a very bad problem, and a lot of people think they have Meniere's disease when in fact they don't. So there are a number of tests that we can do to identify in fact is it Meniere's disease or not. So Meniere's is a sudden onset of vertigo, unilateral hearing loss, and commonly a roaring tinnitus, not a frequency specific tinnitus, but a roaring noise in the ears, lasts anywhere from 10 minutes to 10 hours. And then all the symptoms go away completely. The next day you have no, commonly, the next day you have no hearing problem. Your vestibular system recovers and the tinnitus goes away. And then 6 months may go by, maybe 6 weeks, and then all of a sudden you have another episode. So trying to sort out, is that in fact Meniere's disease, or is that any other thing, can be done quite well. And then just have to manage the disease, sometimes with diuretic medication, lifestyle changes for diet, etc., to manage the issue. But it's not something that it goes away. If it's untreated, unmanaged, you end up burning out the ear. Essentially, your vestibular system on that affected side no longer functions, and you have no serviceable hearing in that ear, and where hearing aids can't help, and the tinnitus is quite bothersome. So it's a miserable disease to have if it's not well managed.
What are the diagnostic tests? Because usually we just, it's just a history diagnosis that the people have one of those three components, or ultimately all three of them, maybe at different points in time.
Early onset Meniere's disease, it's best to see the patient when they're symptomatic, but when they're symptomatic, they're throwing up and they don't want to move at all. But as soon after the vertigo episode subsides, measuring the hearing acuity, it's the common hearing loss is a low frequency hearing loss and normal high frequency hearing. There's a unilateral vestibular deficit. We measure the balance system and we see a reduced function on the affected side. We do a diuretic challenge test with the patient, in that we provide two types of tests. One is using urocanic acid mixed with apple juice. The patient drinks that as the diuretic. We check their hearing every hour for 3 hours, and if they are symptomatic, and if they are in fact do have Meniere's disease, there's a significant recovery of hearing for a temporary period of time. Another test is a glucose tolerance test. They drink a heavy dose of glucose, and we measure the hearing also. There's also there's another test called electrocochleography. We measure the function of the cochlear micropotential within the inner ear. And that's just, those are brainstem evoked response measures. So there are a number of tests that we can do to help identify the diagnosis of Meniere's disease. So episodes of dizziness is not, I mean, it's rare. There are cases of they don't have the triad of symptoms. They just have the vestibular symptoms, and then later on the auditory symptoms come into place, but episodic bouts of vertigo lasting for hours at a time. But we have discovered over the years is that episodic bouts of vertigo are more of a migrainous subvariant called vestibular migraines. And those have been misdiagnosed and been called Menieres disease for long periods of time. We do have better techniques of measuring functional performance, but the patient's history is a huge guide into what tests we decide to do to evaluate the patient's responses.
Any other questions from our audience? I was always taught to make a distinction between just dizziness and true vertigo, where people could tell that the plane of motion was specific, up, down, left, right, as opposed to just not just mild, non-specific dizziness.
Non-specific dizziness, it's really, I mean, the whole 80% of my diagnosis on balance patients comes from their history. And then I use the test to confirm or deny my impressions. But dizziness is really a bad description of a balance problem. Is it a woozy lightheadedness sensation, which may be more of a blood flow issue? Orthostatic hypotension is a common problem that occurs with patients. They get up quickly, they get up out of bed, or they bend over to pick something up off the floor, and then they stand back up. They get a woozy lightheadedness sensation, and that's commonly orthostatic hypotension. There's another phenomena where I talked about those calcium carbonate crystals. They can get loose from the otolith organ. They float around in the fluid and they land in the semicircuit canal and bump up against the cupula, which then provides bad data to the system. It tells your brain you're moving when you're not. So it causes, you put your head back in bed, you roll over in bed from one side to the other, or you look under a cabinet to pick something up, and you get a sudden burst of spinning. The reason you get the sudden burst of spinning is that those calcium carbonate crystals are impinging on the cupula and telling your brain that you're still moving. And that sends a signal to move the eyes in response, and you spin like a top. And that is a big problem and a common problem and the most common complaint of vertigo. And that can be easily and quickly treated and cured within one day, doing special physical therapy maneuvers to move those particles out of the offending area and no longer causing problems. So vertigo is kind of a magical mystery tour, and that's been my interest for years of trying to solve the riddle of the patient's complaint. But wooziness, lightheadedness sensations, mobility functions, ability to move about in space, and safety is of important to get that nailed down. As you get older, your functional performance changes and you become at risk for falling. After age 80, you fall twice within the same year. You have a 50% chance of not seeing your next birthday. And it's the consequences of the fall, the onset of pneumonia and other issues that come on as a result of hospitalization because of falling and breaking your hip. So movement issues become more and more become more and more of a concern as you age, if you want to age in place.
This is, vinod, Doris, one of the practicing allergists in the community. Thank you for a very helpful talk. I really appreciate it. And thank you for taking my questions. I had a couple, you can hear me?
Yep, I can hear you just fine.
Okay, perfect. So, are there any clinical clues where you start, that differentiates something more benign versus, again, a cerebral pontine tumor, or, that you probably need more urgent referral? Second is there a difference in terms of prevalence of, inner ear disease in those with just pure allergic rhinitis to those with, say, chronic sinusitis with or without polyps, or is there a difference between those two in a sense of inner ear disease?
Trying to remember both questions. I'll answer the last question first. Is it there's no evidence of inner ear impact from sinusitis or other inflammatory conditions within the sinuses. It impacts the middle ear system significantly, just the ability to ventilate. The eustachian tube opens 300 times a day to provide oxygen to the middle ear space because the mucosal lining is absorbing that oxygen throughout the day and it needs to be replaced. If it isn't replaced, it causes negative pressure, which then sucks fluid from the mucosal lining and fills up with fluid, and then it can get infected and then creating other, through bacteria entering through the eustachian tube from the nasal pharynx. That impacts the middle ear system. Does not. Sometimes aggressive bacteria can invade the cochlea and create hearing issues, but it's not a common phenomenon. One of the things I forgot to mention, and it's very important, if you see a patient that complains of sudden hearing loss, they can't hear out of one ear, the problem in the past is that the physicians have just said, okay, it's a middle ear problem. Here's some antibiotics, or here's something to do to try and clear it up. And that's not likely the case. It can be a sudden sensory neural hearing loss. And if they are not treated within 5 to 7 days, the hearing will not come back at all. It's a treatment injection of steroids into the cochlea through the tympanic membrane, treatment right away. Sometimes the oral steroid treatment is done also. 30% of those that get treated right away are going to have complete recovery of hearing. 30% of those that get treated have a partial recovery of hearing. And 40% get no recovery at all, and they become deaf in that ear. And the later you get started on the path of treating that, the lower the chances of any recovery whatsoever. So if you see a patient that complains of sudden hearing loss, the ear is plugged up, you do an examination, you find it's obviously not cerumen, and there's no evidence of middle ear fluid, sending them to an otolaryngologist for treatment right away is really, really important. And I've seen thousands of patients in my career where I've seen that occur, where patients were not treated properly and they end up with complete hearing loss. So I talked a lot. I don't know if I answered both of your questions in that thing, but
Any other questions before we let Dr. Mallahan go? Do we routinely test newborns for hearing? Is that a requirement?
We in Snohomish County, and we started a demonstration program in 1998. And I got a federal grant to start newborn hearing screening testing at all 4 hospitals. And we demonstrated the efficacy of testing. And now all children born in Washington State get a hearing test within 1 month of birth. If they're born at a birthing center, they return to some facility, and the Washington State Department of Health monitors the screening, and 96% of all newborns get a hearing test within the first month of life. And it is common throughout all 50 states. And happily, I have started a newborn hearing screening program within Guatemala in the last couple of years through Rotary grants. So they have 10 times more children with hearing loss than we have here. So luckily, most every child gets a hearing screening at birth. And we can get them, if they are deaf, we can get them fit with cochlear implants, bilateral cochlear implants within a year of life. And by the time they get to kindergarten, you cannot recognize them from their normal hearing kindergarten classmates because of their access to sound and speech.
All right, well, I think we'll let you go. Thank you. As I said, it's very pragmatic stuff that in general, we as allergists are taught very poorly, so much appreciated.
Thank you for the opportunity to share.
All right, so long.